Thank you for the opportunity to present in this forum. My name is Simhan. I'm a maternal fetal medicine physician at UPMC Women's Hospital in Pittsburgh, and I'm the executive vice chair for obstetrics for the Department of OBGYN at the University of Pittsburgh School of Medicine. On behalf of myself and Beth Quin, who will be presenting shortly, we're pleased to present our work on a postpartum hypertension remote monitoring program. By way of brief clinical background, hypertensive disorders of pregnancy complicate 10 to 15% of pregnancies. These are conditions including preeclampsia superimposed upon chronic hypertension, gestational hypertension, and eclampsia and HELLP syndrome. These complications are a major cause of both maternal and fetal and newborn morbidity and mortality worldwide. It is the leading cause of postpartum readmissions and increased costs and intensity of care in the postpartum period as well. In the US, maternal morbidity and mortality has continued to rise despite improvements in technology and greater understanding of the biology of pregnancy complications. But still, the public health phenomenon of rising maternal morbidity and mortality has been, unfortunately, part of what we've had to deal with in the US for nearly 2 decades. With respect to the postpartum period, is a particularly vulnerable window. It is a period of time of less direct healthcare and oftentimes can be an arena and a time period in which there's unmitigated risk through the usual structure of care. By history, follow-up care after a birth in the US is a face-to-face visit with an obstetrical provider at 4 to 6 weeks after birth. The American College of Obstetricians and Gynecologists advise the importance of appropriate postpartum care and have emphasized the importance of this postpartum period by labeling it the 4th trimester of pregnancy, giving it a degree of importance that the usual 3 trimesters of pregnancy do have. And for women with hypertensive disorders of pregnancy, a recommendation has been promulgated in the US that a blood pressure is checked within the first 10 days postpartum and then again at 4 to 6 weeks postpartum after delivery. The notion of remote blood pressure monitoring is that it can provide us the opportunity to check blood pressures at these time intervals in a lower resource, less expensive, less burdensome manner for patients, and furthermore, fill in the time frame in more continuous fashion rather than just these 2 discrete blood pressure checks. The notion of checking blood pressures, symptoms, and managing patients as a continuum across this epoch of time is an opportunity afforded to us through remote blood pressure monitoring. In our program, we identify eligible patients at the time of birth and the immediate postpartum period, women with one of the hypertensive disorders of pregnancy who deliver a baby at UPMC Women's Hospital, as well as 2 of our rural UPMC hospitals here in Pennsylvania. Women are identified as having had a birth with these complications and then are enrolled on the floor and educated prior to discharge as to the nature and importance of the program. This is a bring your own device program. Blood pressure monitors are provided to patients. These are blood pressure monitors that are validated for use and are also calibrated against blood pressure cuffs in the hospital. Importantly, these are simple blood pressure cuffs. They are not Bluetooth enabled. They are relatively inexpensive for us to use, but are validated tools. The patient uses her own smartphone device, and the requirement is that it is text enabled. We utilize a monitoring platform that's integrated with the electronic health record. We order the program through the electronic health record, and program output from the program platform can be viewed within the electronic health record. So providers at any point in the postpartum period can follow blood pressures or see symptoms moving forward. And we feel like this integration is really important to connect the remote monitoring program to the care providers themselves. The program duration is for 42 days postpartum, that first 6 weeks. The sort of human structure of the program is a core team of maternal fetal medicine providers, physician providers, who are the clinical experts and the physician leads and backup to a call center. We have a program call center with trained nurse specialists who follow established algorithms, evidence-based algorithms, to manage the condition symptoms, preeclampsia related symptoms, and blood pressures using the algorithms we've pre-specified. Through the program, we can remotely initiate, titrate, and discontinue antihypertensive medications, direct the immediate needs of care to the patient. If a patient does need emergent resources based on blood pressures or symptoms, we can connect with them and emphasize to them to present immediately for care. And we can educate and assist with connection to primary care beyond the episode of pregnancy. Hypertensive disorders of pregnancy are an important contributor to later life cardiovascular disease, and that handoff to primary care is incredibly important to reduce the burden of this disease over a woman's lifetime. The goals of our program are to increase patient engagement and care, keep patients connected to the ecosystem with an integrated platform, decrease unnecessary ED visits and readmissions, but also, as a corollary of that, bring patients to the ED and bring them to the hospital if we need to prevent them from having a catastrophic outcome, and improve the collaboration of care beyond the episode of pregnancy and that transition to primary care. Next, I'll transition to my colleague, Beth Quin, who will present some more features of our remote monitoring platform.
So my name is Beth Quin. I am the Director of Women's Health Operations here at UPMC McGee, and I am a nurse by background with UPMC for over 20 years of experience in obstetrics and women's health. I have the pleasure of overseeing this program for the last 4 years since we implemented that in February of 2018. So this is some of the features of what our platform looks like for a patient. When they are enrolled in the program through the postpartum unit or in one of our outpatient offices, or our emergency department as well, they will receive a text link that would take them to these screenshots just to give you an idea of what it looks like. So we thought it was important that they would see some videos for interactivity with our providers. Dr. Simhan, being the medical director of our program, has recorded several videos where we introduce the program, the disease for the patient, explain to them what that is, the importance of belonging to this program, and thank them later throughout the 6 weeks for participating, and really stress the importance of continuing their care, continuing to monitor their blood pressure, and follow up with their obstetrician and primary care physician. Some of the other features that have been added to our platform here, we have some tabs at the top that the patient can then communicate with their nursing care team on the other end of the call, with requesting a phone call from them, text messaging real time to them. The call center is open 7 days a week on normal business hours, so the patient can get a call back from the call center if they have some questions. They can also begin to track and trend their own blood pressures on there, because there is a tab where they can see what they have done. They can share that if they were to go back in for care to their provider, or if they presented to the ED, they would have easy access to see what that looked like for them over their time in the program. So through this link is where they will enter their blood pressure, their heart rate, and answer several questions for us as well. We had designed several questions based on symptoms to know what is happening on the other end for them. So we ask how they are feeling compared to the last time they talked to us. We ask if they had been seen by a provider in their ED or their primary care provider since the last time they had entered a pathway. And we ask symptomatic questions to assess what their condition is at the time that they are telling us their blood pressure as well. We ask this daily, just once a day in the beginning of the program for the first few weeks. We will then start to taper back depending on if the patient is in a medicated or non-medicated pathway for us. At the bottom is just to show you what the portal itself looks like. On the other side for the nursing call team, they have a quick reference at what the patient, some of the important things of the patient they're able to enter in there and what their blood pressure is. They can click into the site and see all the patients actively and what's been happening with them and answering their pathway questions. We identified medium and high risk conditions based on the symptomatic questions and based on blood pressure, different levels of the blood pressure, and that helps our call team to identify if it's something they should triage the patient to rather quickly or call the patient back and assess more thoroughly what is happening in their condition at home, if they need to reevaluate a blood pressure or contact our provider care team to titrate the medications. So again, just to reiterate, so we have the nursing call center, which will take all of the input of information from the patients. They use the evidence-based algorithms that we have designed for both a medicated and a non-medicated pathway, to which they can do some immediate triage, or else they know to call the provider with the further assessment and information to get titration of medications, implementation of medications, or just to hold and evaluate if that's the case. And we have a core team of providers that we have started. We started with a core team and have continued with just a little bit of change, but keep it in that small group so that we find that to be really an effective way to manage this population of patients. And we get the report weekly dropped into our electronic health record so the providers are able to see that as well. Just some of our statistics for the program. Like I said, we started in 2018 for the program. We have grown over the last several years to spread from just one hospital at McGee to 2 of our other northern hospitals that are smaller rural hospitals. We have ordered the program on over 5,000 patients to date. And on a current average daily census, we manage for over 200 or 230 patients a day are being managed and monitored through the program. We found that important over the last few years. The first year we did a lot of manual data collection and realized that we needed to have some kind of an outlet where we would have all of the data that we needed flowing into a dashboard for us to monitor. And so we worked with our clinical analytics partners who have created this fantastic dashboard for us so that all patients that are ordered and enrolled in our program, we have information at our fingertips to filter on to see who they are and what's happened to them during the duration of the program and in the postpartum period as well.
In terms of learnings from our program experience to date, because we've had unique insight into the trajectory of hypertension in the postpartum period over the first 6 weeks postpartum, there are things about this clinical condition that we've learned that were unknown in the obstetrical literature. By checking so many frequent blood pressures and their trajectory and the symptom complex, the evolution in the postpartum period of preeclampsia is really better understood now through this program than it ever had been before. We found that a large proportion of women remain hypertensive at 6 weeks postpartum. By the conclusion of the program, 50% of women remain hypertensive. That is really important to understand because that helps define a degree of the need for ongoing primary care and blood pressure and other cardiovascular disease risk mitigation. A full third of women in the program require antihypertensive medications to manage their blood pressure as an indicator of the severity of that hypertension. So it's a point I made earlier, but our data and experience to date really do emphasize that this is an at-risk population. It is essential to make sure that we manage blood pressure well and emphasize that transition to care. In terms of the blood pressure assessments, 43% of patients are seen for an in-office visit at 7 to 10 days. That means the majority of women are able to just be managed as an outpatient, and 57% don't require that in-clinic visits in that first 7 to 10 days. So we're able to still manage them and take care of them and reduce the expense and burden of an in-clinic visit. Furthermore, by engaging in the program, we increase the adherence with the face-to-face postpartum visit at 4 to 6 weeks. 85% of program participants are seen for a postpartum visit. This stands in contrast to the extant experience with postpartum visit attendance, which is in many settings in the US in the range of 50% adherence. So by engaging with a population, emphasizing the importance of the condition and providing them this continuity of care, we enhance the participation in postpartum care, which is good for blood pressure care, but also other elements of postnatal recovery. In terms of engagement through the first 4 weeks of the program, that engagement is high. We know that we text message within the first 10 days, and initial engagement is quite high, 92%. And through 4 weeks, it remains high, 72%. There's a degree of attrition, of course, with and any program like this will see that, but it's quite high. And digital engagement programs in the healthcare space often don't come close to this degree of engagement. So we have been quite pleased with patient engagement. And in terms of sort of direct healthcare utilization related outcomes, this graph depicts the frequency of readmission rate for hypertension. On the left of the x-axis is January of 2017, and it's the months go forward as you go rightward to March of 2021. And the point estimate of readmission frequency is that dotted green line. We've seen a steady reduction in readmission. Key program milestones are marked with those blue bubbles. We initiated the program in March of 18. Standardized bedside education to patients with the core team, did a marketing push, but also a direct focus on centralizing and coordinating the education to patients in March of 2019. And in March of 2020, we extended our weekday coverage only program to 7 days a week. And we've seen and enjoyed a steady reduction in readmissions since that time. So that has real patient experience implications as real cost and quality implications as a direct result of the program. In conclusion, we feel like our postpartum remote monitoring program and programs such as this one can improve adherence to care, improve the patient experience, reduce hospital readmissions, reduce racial disparities. I didn't spend a lot of time talking about that in the primary presentation, but we're certainly glad to take questions about that. We have seen, just briefly, we have seen reduction in the black-white disparity in blood pressure and management of that blood pressure. There still is a disparity here in our area and in the US, but we feel like this approach helps to narrow that. And then we also think that a program such as this one helps us engage a population and to begin the management such that we can improve maternal cardiovascular health over the lifetime, which is one of the biggest contributors to the cost of healthcare as well as morbidity and mortality over life. Operationalizing programs such as this one, reducing barriers to program participation and engagement are necessary to improve outcomes for all folks, to reduce disparities, to improve equity, and be the rising tide that floats the ship of enhancing maternal health and reducing morbidity and mortality. I'd like to thank you for your time and attention and appreciate the opportunity to have presented today. Thank you.